Important NCLEX note on GI system. Let's start from peptic ulcer disease. This is the most common topic for the NCLEX. There is ulcer formation in mucosal lining of the stomach, duodenum or esophagus. According to the area affected, it is divided into three types. If ulcer occurs in the stomach, that is gastric ulcer. If ulcer occurs in the upper part of the small intestine, that is known as duodenal ulcer. If ulcer occurs in the lower part of esophagus, that is known as esophageal ulcer. For the NCLEX, you must have to know that the difference between gastric ulcer and duodenal ulcer. In gastric ulcer, the pain becomes worse with food, and in duodenal ulcer, the pain becomes better with food. Now let's go on the causes and risk factors. H. pylori infection is the most common one, and other risk factors are NSAID like aspirin, brufen, and other triggering factors are smoking, alcohol, stress, spicy foods, and Zollinger-Ellison syndrome, which is rare condition which causes the excessive acid production. And let's go on sign and symptoms like pain in epigastric region, uncomfortable bloating, burping, dark tarry stools, GI bleeding, pain relief pattern which depends upon the gastric ulcer or duodenal ulcer, appetite changes, weight loss or weight gain, indigestion, dyspepsia, nausea, vomiting. For the treatment, antibiotics like amoxicillin, clarithromycin, a proton pump inhibitor, PPI, estrogen receptor blocker, and antacids are used. And in endless questions, in case of case study type question, we can get different case study on the peptic ulcer disease. So for that, we need to understand the important nursing interventions. We can memorize that by ulcer mnemonics. First of all, we need to understand the triggering agents like NSAID, alcohol, smoking, stress, and the lifestyle changes are important in this case: stopping smoking, avoiding spicy acidic foods. Check for H. pylori infection by urea breath test, stool antigen test, and educate regarding medication and diet. Report complications like perforation, GI bleed, or obstruction. Always report sudden severe abdominal pain that is related to perforation. Like symptoms are rigid board like abdomen, hypertension, and tachycardia. This case is always the priority in any type of question, either case study or priority wise question. And other symptoms to report are bright red or coffee ground vomit, which indicates active GI bleeding. Report black tarry stool, which indicates GI bleeding. Emergency if accompanied by dizziness, low blood pressure, high heart rate, which are the signs and symptoms of shock. Persistent vomiting, weight loss can also complicate to the situation, so we need to report this condition as well. For the NCLEX, must know the difference between upper GI bleed and lower GI bleed. In case of upper GI bleed, there is always black tarry stool, and in case of lower GI bleed, there is like bright red maroon colored blood in stool. Now let's go on gastroesophageal reflux disease, which is also known as GERD. In this condition, there is backflow of gastric contents into esophagus due to relaxation or incompetence of the lower esophageal or cardiac sphincter, which causes irritation into the esophageal lining. The signs and symptoms are heartburn, burning sensation in the chest, regurgitation, sour or bitter tasting fluid in the mouth, dysphagia, difficult swallowing, chronic cough, hoarseness, epigastric pain, globus sensation. For the medical management, antacid, magnesium hydroxide, calcium carbonate are used to relieve the symptoms. Proton pump inhibitors, histamine estrogen receptor antagonist are also used. Do not give these two in combination. And for the nausea or vomiting, like prokinetic agents are used, for example, metoclopramide. And being a nurse, teach regarding lifestyle modifications to the patient, like avoiding trigger foods, eat small and frequent meals, avoid lying down after food, elevate the head of the bed, quit smoking, avoiding alcohol, losing weight. Okay, now let's go on another topic, that is appendicitis, which is also the important part for case study type questions. The infections enlarged lymph nodes, stricture, fecal marks, worms, foreign body, tumor, trauma, injury can lead appendicitis. And here are the signs and symptoms. In all symptoms, periumbilical pain start around the navel, then shifts to the right lower quadrant, anorexia, nausea, vomiting. These late symptoms are like MC Bonney's point pain, rebound tenderness, rupturing sign, low-grade fever, gardening rigidity. The important one is knowing appendix rupture. There will be sudden relief of pain followed by severe generalized pain, which indicates peritonitis. The nursing interventions and priorities include pre-op interventions like giving patient in NPO, IV fluids, pain management, no heating pads, use cold packs instead, avoid laxative enemas can cause rupture. Positioning, we provide semi-forward position. In post-surgery phase, early ambulation, pain control, incentive spirometry, and deep breathing exercises needed. Monitor for infections like sign of fever, redness, swelling, and we continue diet from clear liquid to soft, soft to regular diet. And the complications are also important parts to know on this topic, like peritonitis. This is life-threatening condition. The symptoms indicates peritonitis are rigid board-like abdomen, severe pain, fever, tachycardia, hypotension. If paralytic ileus occur, there will be absent bowel sound. So in this case, emergency surgery or IV antibiotic are needed. Okay, now let's go on cholecystitis, which is also known as gallbladder infection or inflammation. This condition often occurs due to gallstones or cholelithiasis, which causes blockage in the bile duct. The sign and symptoms are, we can also refer it from mnemonic, that is gallbladder attack, like abdominal pain, tenderness, tachycardia, fever, anorexia, nausea, clay colored stool. And the priority nursing interventions are keeping on NPO, IV fluids, antibiotics, low fat diet. In case of surgery, laparoscopy cholecystectomy is done, and bile flow monitoring is also needed. Look for complications like peritonitis, pancreatitis. Analgesic are also used. In case of drain care is needed. Other things are deep breathing exercise, early ambulation, education on dietary changes, and in severe cases, cholecystectomy is also done, which is removing gallbladder. And for the medical management, painkillers are used, antibiotics, antiemetics are also used. Sometimes the cholecystitis can lead severe infection or sepsis. So sign and symptoms to report are severe are right upper quadrant pain, fever, chills, tachycardia. In case of bile duct obstruction, there will be jaundice, dark urine, clay color stool. And in case of perforation, peritonitis, rigid abdomen, hypotension, rebound tenderness. So always report these conditions. Now let's go on intussusception. It is invagination or telescoping of one portion of the bowel into another portion. The main cause of intussusception is unknown, but it is most common in infants and young children aged between 3 months to 3 years. The clinical features are sudden intermittent, severe crampy abdominal pain, probable sausage-shaped mass on upper right abdomen, and in case of case study typification, if you see that there is palpable sausage-shaped mass, you can think about this condition. Current jelly stool containing blood and mucus, colicky abdominal pain, cyclic repetition of symptom at approx every 15 to 20 minutes interval. Child may appear normal and comfortable between episodes. Bile stain, fecal emesis, hypoactive or hyperactive bowel sounds, tender, distended abdomen. Being a nurse, monitor for sign of perforation, peritonitis. Monitor for the passage of normal brown stool, which indicates that the condition has reduced itself. With the hydrostatic reduction, most cases are successfully treated if no sign of perforation or shock. In hydrostatic reduction, the Ayres line or barium enema is used to exert pressure on area involved to lessen the prolapse. Now let's go on another topic, that is hepatic encephalopathy. This is a life-threatening complication of liver disease that occurs in severe liver failure. Ammonia is considered the main factor in development of hepatic encephalopathy. Ammonia enters into the brain and excites benzodiazepine receptor, causing CNS depression, which produce sleep and behavior patterns noted in hepatic encephalopathy. It is caused by severe liver failure associated with portal hypertension, can improve with recovery of liver function. Excess diuresis, dehydration, infection, surgery, fever, sedatives can also trigger the condition. The clinical features depends upon the stage of hepatic encephalopathy. In stage 1, mild confusion, mood changes, slight tremors, difficult with attention. In stage 2, lethargy, asterixis, personality changes, slurred speech. In stage 3, marked confusion, hyperreflexia, severe asterixis. In stage 4, coma, unresponsiveness, positive Babinowski sign. And the main nursing priority are assessing patient mental status, assessing patient daily weight, IO, vitals, monitoring serum ammonia level, monitoring electrolytes, fluids, restrict protein, avoid animal protein and substitute, enteral feeding for patients who stay in encephalopathic state, reduce ammonia level by GI suction, enema, antibiotic and laxatives. The treatment is aimed at eliminating precipitating cause and minimizing potential complication. We need to lower the ammonia level by lactulose. IV glucose and vitamin supplementation can be done. We need to avoid hepatotoxic drugs, avoid protein overload, prevent constipation.